Hi, welcome to this Hong Kong stand at TCTAP2022 session. So we are, on behalf of Hong Kong stand, I would like to thank TCTAP for their very kind invitation each year. And we are very honored and delighted to have this partnership session with TCTAP. So this morning, we are going to have a special session on the management of hemodynamic crash and cardiac arrest in the cath lab, a very exciting topic. So co-moderating the session with me would be Dr. Doug Woo Park and Dr. Michael Lee. And we have a distinguished panelist with Dr. AJ Curtin from USA, Dr. Alan Chan from Hong Kong, Ho Lam also from Hong Kong, and Dr. Alan Young from USA, and finally, Dr. Ka-Long Choi from Hong Kong. So without further ado, I'd like to start the session. So the first speaker would be Dr. AJ Curtin from Columbia Medical University Center, USA. So he's going to talk about overview of cardiac arrest during coronary angiography and PCI.
Thank you so much for having me. It's a real pleasure to be here. I unfortunately can't be there with you in person, and I know all of us are missing this for 2 years now, but I have hope that this will happen soon, that we can all be together. I'm going to be talking a little bit in an overview fashion about cardiac arrest during coronary angiography and PCI. There's a case to follow. We're also going to go into other topics as well. So this is overall a very exciting session. As mentioned, sometimes the excitement is not good in the cath lab. It's nice to be calm. But anybody who does what we do knows that you can be calm in an emergency, and that's what this talk is about, how to sort of train to be able to do that. Here are my conflicts, none specifically relevant to the talk. You know, cardiac arrest in the cath lab is often called unexpected hemodynamic collapse. And this is a slide I borrowed from Craig Thompson, who presented on this topic at TCT earlier this year. And by definition, it's a patient who's previously stable who develops threatening blood pressure, rhythm, and respiratory compromise during the course of a cath lab procedure. That could be a dissection of the right coronary during angiography. That could be no reflow during your PCI or a perforation or anything like that. But the key thing about being calm in an emergency is that complications should not be fully unexpected. One should always sort of look ahead and think what can happen in this circumstance, and not to overreact to it, but to understand how to be prepared for it and to be prepared for the consequences that occur. And that's really the key issue with how to deal with this. Now, one of the challenges, though, with hemodynamic collapse and compromise is you take a stable patient and things are going smoothly, and then all of a sudden, unexpectedly, so you get caught off guard, there are many potential etiologies for what could be causing the problem. There's often minimal time to be able to reverse it and to fix it and to stabilize the patient. And just in general, it becomes a poor environment for multitasking. You have to manage a team, you have to manage a patient, you have to manage the coronary, you have to manage the hemodynamics and the airway, all of this stuff at the same time. And what's interesting psychologically, if you do some analysis of this, is that humans aren't really that good at multitasking. We often talk about multitasking as somebody or as a measure of somebody who's super effective. But the reality is the more things we try to do simultaneously, we slow down and actually tend to do worse in those ways. So what we actually do is we switch from task to task rapidly, and that can be inefficient and it can reduce our productivity as a whole unless we start moving in one direction and assign that to somebody, and then things move in parallel, and that's the real way we ought to do this. And so what we really need to do is figure out what we have time to do when, to assign things to somebody else, and then move on to the next task that we can accomplish. And that's really the key thing about managing these complications in the cardiac cath lab. So this is an example of a patient that was in our cath lab a few weeks ago. And I think that you see here, this is a type of scenario where we see this. And if you start thinking and starting to say, well, what is going on? How is this happening? By that point, the patient could almost be arresting. And so if you don't act first and think second, then you're going to have real issues. And I know everybody is going to be nervous about watching this and seeing how long I'm showing this for, but thankfully at this point you start seeing the rhythm come back, and this was actually an air embolus case that occurred during a PCI where the manifold wasn't flushed as well. So this gets to sort of this paradigm that we published in this review article in 2020. We have a complications course that we put on through CRF. This is through Bill Lombardi and his group. And we had 2 years of this course, and we came up with a bunch of algorithms, and we synthesized them in this paper in Circ Interventions. And the first one for a catastrophic type of complication is a decision-making point. And the real question that you have is, do you have 60 seconds or even 30 seconds to try to figure out what's going on? If you do, then you can think first and then ask for help and act second. And when you think of the differential diagnosis, all the different things it can be, and then you sort out what goes on. There are other complications, though, like the one I showed you, where you actually don't have 60 seconds, because that patient, if you wait too long, that patient's going to arrest. And so in those cases, you have to act first, then you start thinking second, you ask for help, and then as the patient gets stabilized, you can then determine what needs to happen. So that aspect of things, that 60-second rule, is a nice way of thinking through this and to sort of hardwire into your cath lab what action stations will happen if this rhythm, like I showed you, occurs in the lab. Now, there are other cases, though, where preparation can be really, really important. And this is a case that we had in our lab a few years ago, which is a patient who actually came in with non-STEMIan shock, didn't have a critical culprit lesion, but had severe multivessel disease, had an occluded right coronary artery, an EF of 20%, was having VT, had a balloon pump in for stabilization for chronic heart failure after this had happened, and then the balloon pump came out for an ischemic limb. And the patient came to the cath lab to determine whether this LAD ought to be revascularized, and during IVUS catheter in the vessel, the patient started coughing and having difficulty breathing. And one of the things that's very important to identify upfront going into these cases is how much reserve a patient might have. This patient, with the things that I've shown here on the right side of the slide, has very little reserve. And so an IVUS, which is typically a benign thing, if it makes this LAD territory ischemic with an occluded right and a low EF, this patient can be in trouble. And there was a delay in stabilization of this patient, giving them respiratory support. And as that happened, then the patient VF'd and VT'd and VF'd, and ultimately spent 3 weeks later in the hospital, had to be put on ECMO, have CPR, and all of these other things. Now, the problem for this was that algorithmically, the operator did not recognize, number one, the patient was at risk, and number two, by just having ischemia in that LAD, the patient was going into pulmonary edema, which then primed them for a respiratory arrest, which then led to this whole VF cycle. And so the idea here is if you see an acute drop in blood pressure, you really need to think, is it real? If it's real, do I need to fix it quickly? And in doing so, have this differential diagnosis that includes, ischemia, rhythm issues, cardiac performance or pump dysfunction, bleeding, which is an important one, and then things like vasodilatory problems like anaphylaxis or otherwise. And if it's not quickly reversible, you need to support these people rapidly. I'll also say that there are more benign causes of hypotension, things like the vasodilator cocktail given after a radial access, things like oversedation, vasovagal from patients with urinary issues whose bladder gets distended on the table. These things are more benign, these things are more severe, and in your mind, you really have to come up with an idea quickly, reverse the hypotension rapidly, and then try to stabilize the patient. This issue of pre-procedure assessment, I do think, is an important aspect. I know I was supposed to speak about what happens if you arrest, but I think it's also important to go into the case, as I said before, prepared about who might have an arrest. And these are 3 identical hypothetical scenarios with patients that have a mid-LAD 90% and approx right coronary 80%. Here are the hemodynamics, including right heart pressures. And on the left of the slide, you see this patient is totally compensated. Normal blood pressure, normal PA-SAT, wedge of 14. On the right here, you have a patient with the exact same anatomy who is at high risk for compromise during the procedure. This patient might not even be able to lie flat during the procedure because the wedge starts at 33 and the PA-SAT is 38 with an index of 1.4. And this patient in the middle is a patient that's sort of between the two extremes, has pulmonary hypertension, the wedge is elevated as well. In this case on the right, what we might often do is not even do coronary angiography. We might just do the right heart cath, stop, stabilize the patient before we allow that patient to lie flat for longer and have to go through the ischemic insult of a coronary PCI or otherwise. Whereas on the left, we would proceed normally. And this is one of the reasons why I think it's really important to get a good hemodynamic assessment. The reason hemodynamics are so essential is because, remember, catheters obstruct aortosteal flow. contrast, when you inject it, depresses the myocardium and also doesn't contain hemoglobin, so your patient gets ischemic. And then whenever we do our interventions, the patients always get sicker before they get better. And that's a fundamental premise we teach our fellows. If you ignore the hemodynamics, it makes it difficult to do the case, and the patients will get sicker during the case. So that brings us to the question, if you have to do the case, can we be prepared? And the idea is, yes, you can be. You can consider support if you're really working on a last remaining vessel, severe LV dysfunction. And I'm not going to go through all these algorithms because I'm sure they're going to come through in the case itself. But the idea here is if you have a sick patient with bad anatomy, those are the cases for whom we consider prophylactic support. And support can improve complications. This was actually a randomized study of the balloon pump versus placebo for high-risk PCI, and there was a reduction in periprocedural events. I would argue that's the most important reason to put in hemodynamic support rather than things like MACE or mortality or anything like that. The reduction in hypotension, VTVF, or CPR, it was enough, even with a balloon pump, in this randomized trial to show a difference. So the sickest patients can benefit from support. Now, many of you outside the United States think we use hemodynamic support like water. We use it too frequently. We might overuse it. I will show you, this is data from our site where we basically use support in the vast minority of our cases, really unprotected left main, less than 10%, multivessel disease, even the EF that's low. We don't use it every time. It's just the specific cases where the patient's decompensated and we're going to be doing a lot of work. I'll end by just showing you this case. This is a case of a patient who had grafts that were known from before, had a non-STEMI with anterolateral depressions, and this was the entire graft supplying the entire heart. And during the diagnostic angiogram, something must have embolized to this distal portion of the graft, and you see there's no heart function, no beating, and this thing is going nowhere. This is the type of case where, again, remember that 60-second rule. Do you have time to think or do you not? This is one where you have to act immediately. This patient needs to be intubated, fully supported. They crashed onto ECMO in the cath lab, and then we started fixing the artery, because the artery alone is not going to allow this patient to survive the insult to their heart from this thing going down. So key thing here is the patient arrests immediately. You do full CPR, cooling, you try to shock the patient, but you put the patient on ECMO, and then you go forward to fix this artery. And so what we did, while the patient really had barely beating heart, no flow in this, is then we had time, because the patient was supported with fully ECMO and intubation, to then be able to salvage this vein graft. And when we did this, we actually found a lesion at the distal anastomosis. And after this is what the lesion was, and the clot had lodged there, we stented it, and actually this patient ended up surviving, and allowed the patient, and the support allowed us to do this intervention, which required a guide extension put all the way down to here to be able to deliver the stent. So in the end, in terms of support, which is I think a key issue for these patients who arrest, I think we have to measure the goals and benefits, the risks and benefits of what we're going to do. And basically, we know that things like balloon pumps might be able to stabilize temporarily, but clearly don't have enough support. ECMO is great for total crash and burns or oxygenation issues. You sometimes have to vent. And options like percutaneous left side support and even right side support might be needed in specific cases. And the fundamental premise is to support the patient first and then deal with the other problems that are ensuing after that fact. So just in conclusion, in the setting of cardiac arrest or hemodynamic collapse during PCI, you really need to, as a team, identify the potential causes and reverse those causes if they can occur. But sometimes that takes time. And so it's more important acutely to support the blood pressure, rate, rhythm, oxygenation, and ventilation as needed. When you communicate with your team, make sure you sort of have closed loop communication. So don't just say, think about doing this. Give an order, have the person give you the order back, and good teams are very well trained to be able to do this. And ultimately, triage pathways and the use of rapid sequence checklists, I think, are the best methods to balance the needs to quickly assess and appropriately treat these patients. So that's an overview. It'll be fun to talk about the cases, both on the coronary side as well as the structural side. And once again, sorry I can't be there in person, but it's just a pleasure to be able to participate in the meeting.
Thank you, Dr. Curtin. As usual, a very excellent lecture, a very comprehensive review on the topic. And this really set the good stage for our discussion here. So maybe we can entertain a few short questions. Any comments or questions from all the moderators or panelists?
Okay, Alan, you go first.
Ajay, very, very helpful. I think,
most of the other sort of acute teams, such such as trauma team, and in the ER they have simulated training. We don't do that in the cath lab as much. And do you think we should have some sort of a simulation of training, like who does what, right? Because that's usually what needs to be sorted out, but we don't usually think about it. Everybody's different, and then therefore end up confusion.
Yeah, I fully agree, and I think it would be great. We had a remarkable experience during COVID. We were talking about earlier about what's going on with COVID, where there was help that came from a traveling nurse that was just working in the hospital. And it turns out that this traveling nurse, her main job at her own hospital was she would do all what's called the rapid responses. So anybody who arrests in the hospital, she would run the code for that. And it just so happened that that nurse was in the hospital when there was a patient arresting in the cardiac cath lab. So she came down to help. And she ran the entire hemodynamic part of the code, the drugs, the pressors, and all that, while the interventionalist worked on the coronary artery. And we did the debrief afterwards, and the interventionalist said to me, that was amazing. Having somebody that good at doing that part of it, I didn't have to think about that part. I could just think about the rest of it. So I really think that, especially for low frequency, rare events like codes, things like simulations are super important, because then people at least can think through ahead of time, what am I going to do? And you've always seen the attending who freezes when bad things happen. Nobody wants to be that person who freezes, but sometimes if you don't have enough training, you end up being that person.
AJ, thank you for your most enlightening lecture. Can I just ask, you mentioned about preparedness. We agree very much. For like sick patients, poor EF, you mentioned about the hemodynamics, right heart cath, but it is sometimes not the usual practice for all the operators. I would say most operators would not intend to put in the right heart cath before the PCI procedure. Sometimes you will use to use pass the catheter down to the LV to just get the LVEDP. Do you think that is sort of intermediate measures, or is it good enough to just get the LVEDP?
It's a good compromise. I think that if the patient's blood pressure is normal and their EDP is low, you generally can proceed. But what I would say is for the patients that really have LV dysfunction, and I don't mean EF of 40, 45, I mean like 30s and below, the biggest difference of doing the right heart cath, and that's why I spent more time on the hemodynamics, is that we sometimes don't proceed with the PCI. We actually stop, take the patient off the table, optimize their hemodynamics, and then bring them back later, and they might not need hemodynamic support and they tolerate it a lot better. So I think you just have to use your judgment. You don't have to do it, but honestly, we do it from the brachial vein. It's so easy to do, and it's not something that's super challenging. You don't have to go to the groin or otherwise.
Great.
Dr. Carlton, can I ask you about the IABP? So more recently, there seems to be some papers suggesting that IABP may not play a very good role as a mechanical circulatory support. So people seem to play down the role of IABP. So what is your take? Could you elaborate a bit?
Absolutely. And I know we have short time, so I'll make it quick. In florid shock, like the patients in IABP shock 2, the balloon pump is not going to do anything because it has minimal support. But for patients with chronic heart failure, those patients who are sort of tipped over the edge, those with severe MR, and even things like high-risk PCI, the balloon pump might actually do quite a good job. So it's one of those things where you have to, like any device, use it in the right patient population. For some patients, it may be beneficial. For some patients, it's not going to do anything. But a good clinician can tell which is going to be which. And there's nothing wrong with putting it in, seeing what happens to the hemodynamics. And if it's not enough, then going to something more supportive.
Right. Any other comments or questions? Okay. All right, thank you. So I guess another good thing to do would be to attend a lot more of these complication courses so that you learn from the bad experience of other people. So you have some idea in mind when you're faced with this kind of lethal or deadly situation. So this is what we're going to do. So the next speaker would be Dr. Alan Chan from Hong Kong, from the Queen Elizabeth Hospital. So he's going to talk about nightmare case sharing in the cath lab. Alan, please.
Thank you very much for inviting me to be one of the speakers today. Today I would like to share actually it's really not just a nightmare case, but it's a nightmare day for us in the cath lab. So I think I'm going to focus more on the coronary aspect. On the same day, actually, we have a couple of things unfortunately going on. So actually, it's just not a nightmare case, but it's a nightmare cases, and unfortunately, it's a nightmare day for us all in the cath lab. So actually the case was around years ago on the 21st of May. We have scheduled it's one fine morning, and we have scheduled one LA target as well as a few coronary interventions on that morning. So this is our coronary case. This is a 64-year-old gentleman, smokers, hypertension, hyperlipidemias, was scheduled to have stage interventions to the LAD. He first had F1 angina with a positive exercise stress test. Angiogram shows there's a two-valve disease, which in the first sessions, the RCA, distal RCA tight lesion was fixed and bring back the patient for a stage PCI to the LAD. So the RCA is a simple lesions after standing is a good, decent angiographic result. So this is around 10:20 first in the morning, and the patient was brought to the stage PCI to the LAD. So while we had our fellow, our colleagues are doing the case in the other left, we are doing LA target on the other side. So they proceed to the PCI to LAD first as routine through the right radial arteries, IL-35 guide. There's some classification is not really clearly visible from the angiogram. So they use the balloon to blow the lesion up, and because of some calcified lesions, they use a cutting balloon to try to open up the lesion more properly. But unfortunately, they kick the guy out. You can see the guy is always here, and after that, they lost the whole system. So this is what they get, and then they exchange to a better support guy, EBU35, and this is the first shot after they put in the wire. You can see if LAD throw was compromised, and they able to struggle to put in a workhorse wire, run-through wire down to the LAD. According to the colleagues, they don't feel a lot of resistance, and then when they try to pass it down, wire down, we can go as far as here. So and they try to put in the IFS to confirm whether it is true or false lumen. According to them, the thing is a true lumen, and then they further proceed to balloon. But obviously, this is not the case. So at around 11:50, you can see the LED is completely brought out. The patient start to have chest pain. There's SD elevation on the EKG, and at that time, there's zero flow over the LED. So the patient at that juncture, the hemodynamic is still okay, and the colleagues try to do a little bit more wiring using a parallel wire, but however, they didn't really succeed. So unfortunately, another nightmare was happening on the other side. So around 11:18 on the same day, we are doing an LA copy with an SV graph over the aortic stenosis. But I think you can, if you are doing copy, I think you may be able to appreciate the heart function is not beating very well because of the significant AR after the POVA, after the BAV. So shortly after the implanting of the valve, we need to proceed to CPR. So two communication happen at the same time in both cath lab in our intervention centers. So unfortunately for the target case, actually we're doing prolonged CPR. We check everything, including coronary, including the aorta, the aortic annulus, the SS. Nothing obvious cause was found. So we need to put in a support device. The ECMO as well as impeller pacing everything after around an hour of resuscitation. So after we so-called stabilize the patient, we able to leave that cath lab and then let our other staff to take care of the patient, and then we go to the communication in the first lab. So around 12:35, our colleagues put in an extra French shift to do a little more job because we're just doing a 6 French radio access for the coronary at the beginning. So there's not much tactics, gadgets we can able to do. Our colleagues doing a so-called a ping pong guide to do IFS guide real-time wiring to try to figure out whether they can able to rewrite the true lumen from the dissected LED. But unfortunately, it's nowhere able to tell where exactly. And then they pull out the high definition IFS. This is from the tumor. I hope you can appreciate the difference here. Obviously, the LVD, the IFS show the back dissection, the collapsed lumen with the big hematomas all along the proximal LVD, all along to the mid LVD. So, and I think there's no way for us able to rewrite the collapse the lumen from the middle and down, but our colleagues try to puncture again from the very proximal force entry. Probably you can able to tell because of these calcified lesions in the very proximal LVD, the wire goes to the subminimal tract after the loss in guidance. So we try a little bit more antigrade wiring, to do some balloon occlusion, straw, and then try to do some wiring again. But however, everything gets fair. At that juncture, actually, the patient get hemodynamic compromise, as mentioned. To start with, the EF is normal, but however, during the prolonged LVD ischemia, the patient get progressive shock ischemia. We put an impeller CP through the left femoral access, this time ultrasound guided access. We also take a bilateral angiogram through the single access, but however, there's no any retrograde we can able to see. At that juncture, I think you can appreciate hematoma extend all the way from the proximal to the distal LVDs. And also, I don't think a CABG would be a possible option because it's just dissecting everything now. So what will be their final option for this patient after 2-hour trial? The patient is getting anterior STEMIs, hemispheral flow, shock, and this is our only last resort. So with the help of the ping pong guide, we may able to do with the X-branch guide from the right femoral, we can try to do a belt out ADR. In this case, we need to use all the CTO techniques to try to salvage our patients. But we have no retrograde flow, we have no distal vessel visualization from the contrast. So because of the ping pong guide, we may able to use the IFS, real-time IFS, to see where exactly the location is. So after doing a little more straw by proximal balloon occluding, the distal vessels get a little bit more instrument, get a little bit more expanded, and the reduction of the intramural hematomas. You can see the lumen is get a little bit bigger. By using the real-time IFS, we can able to localize the best spot for us to do the ADR. This is the spot which is really have a bigger true lumen here. So this is the real-time IFS guiding the ADR. You can see the stingray balloon here. This is the IFS. I think from together with the angiogram, you can see this is the so-called diagonal side. This is the septal side, and then we are trying to puncture through the septal side here. So according to the angiogram, this is what we are going to facing. So the map-up view of the stingray, this is diagonal side, septal side of the PA cranial wheel. We try to use a static swap technique facing to the septal side. We tried several times of puncture before we're able to pass our wire down to the distal LVD. So we need to confirm, not by angiogram, because we can't see the distal true lumen. And this is by the real-time IFS. You can see our wire is supposed to be inside the true lumen in the mid-distal LVD. So we push the IFS down a little bit more further. The quality of the IFS already jeopardized because we're using that IFS for more than 2 hours after the complications. So this is the IFS from the pullback from distal LVD all the way back. You can see the hematoma is back distally. When you close to the, this is stingray balloon. So we are successfully puncture from the false lumen back to the true lumen. So after we pass in a workhorse wire all the way down to distal LVD, we need to confirm the true lumen all the way from distal LVD before we doing a further job. This is the true lumen from the distal LVD all the way back to the proximal LVD. And this go a little bit further. So it's hematomas all the way, and then this is the probably the proximal entry point from the true to the false because of the proximal calcified part after the illusion balloon. So the rest of the job, we putting stand all the way according to IFS, and then do some massage in the distal LVD because of the hematoma formation. So initially the flow is not very decent. We learned from the Japanese all years before. We can do some more scoring balloon, cutting balloon over the distal LVDs, and then you have long balloon. This is a BDDB, but they intend to do a long, prolonged balloon massaging to the distal LVD to open up the lumen a little bit more. And this is the final angiogram. I know it's not always the best to do a final angiogram, especially there's a lot of hematoma. We need to guarantee the flow is at least is much better than the initial team zero flow. It's at most 2. The IFS also show the angiogram. The lumens get bigger. There's a lot of dissections throughout the distal LADs, all the way standing, proximal to the mid and the distals. And so at progress for the patient is at the beginning, at the end of the PCI, we do again a follow-up rescan, quick echo for him. The EF is of course jeopardized from the normal to around 40%, and we think that the patient still needs some support, and we leave the impellers to the CT with further support. So, but however, because of prolonged procedure, it's almost around 4 hours of procedures. There's some hematomas around the X flange, right femoral sheath. So probably we think there's some bleeding around the sheath. So we and because we need to put in the impellers with ongoing heparin, so we think that we can able to close the wound with the X flange angiosteel and lift the left to the CCU. But however, the case didn't end. There's progressive shock from increasing right groin hematomas, and there's reconstruction of impeller in CCU. So there's also hemodynamic crash, and then bring the patient to the CT and confirm there's still extra contrast extravasation from the right femoral groin wound with retroperitoneal hematomas. I think you remember I first showed you the right groin shot after the during the case, and this supposed to be a perfect common femoral mid-femoral head punctures. Unfortunately, the hematoma tracked all along up. And we need to bring the patient to the OT to repair the groin wound. And from the OT report, actually, we found the reason is actually the angiosteel, the attached strength, it was not all the way to the thoracic wound. It's just in the subcutaneous tissues. And out of surprise, there is also another puncture, small puncture wound distal to the SS. So unfortunately, the patients deteriorated despite the successful vascular repair. The patient also suffering from DIC and also multi-organ failures, and unfortunately succumbed a few days after the PCI. So I think this is a big lesson for all of us, that we, especially when complication arise. Of course, we prepare is very essential. Lots of algorithm to tackling the complications is also important. Be meticulous, I think, is important, especially after the POVA and we lost our guiding position. I think it's not an uncommon scenario. But unfortunately, in this particular nightmare case, a perfect combination of all the combinations, including there's a calcified lesions, there's a bad dissection, we take contrast, the extended hematomas, and strategy to confirm the right position in true lumen before any further PCI is especially important. I hope I can able to share some of the bailout techniques for true lumen reentries after forced lumen wirings, especially if there's no other options. Once MCS is particularly important, including is the hemodynamic crash in the cath lab. And last but not least, always is importance of access management, including particularly also the emergency situations, just like this case. After successful bailout, we our loss of patient because of the groin complications. So thank you very much.
Thank you, Alan. Thank you for sharing this very difficult case. We're sorry about the outcome, but you've tried your very best. I'd like to invite any comments or questions from our panelists.
So I think this is a very, educational case for the beginner or early career interventional cardiologist. Like this severe calcified region, during the complex procedure, if you lose the guide wire, that could be catastrophic. Rewiring is nearly impossible to cross the true lumen. There is a very educational case to the early career interventional cardiologist. That is my comment.
I fully agree, Dr. Park. And Alan showed a very nice case, successfully rescued. But at the end, it's because of the basic groin puncture that actually took the patient's life. Well, I think it is important, especially for the fellows, that even during cardiac arrest crash in the cath lab, you still need a good puncture. Sometimes you might resort to ultrasound guide, even in crash situation, just to get a perfect puncture, try to reduce or avoid the subsequent complications as shown in this very nice case. Thanks a lot, Alan.
Yeah, you know, we have a general rule. One of my attendings taught me that generally speaking, if you're reasonably good, you can get out of one complication. But if you have multiple things happening at the same time, that's when the patients get into trouble. And that's why every subsequent step of what you do has to be done perfectly, because I mean, the save is remarkable. There are so few people, I think, would have been able to do that ADR in that circumstance with the straw and all of that. And yet for the groin to be the issue, it shows you how little margin a really crashing patient has. They've just used up all their reserve.
Yes. I totally agree.
Alan, this is a great case. I think, you know, just going back to the fundamentals, that when you're looking at, you know, doing coronaries from radio, you really need to get quick access of or assessment of how good is the guide, right? Because if your guide is not really good and you're dealing with very calcified vessel, you need to think about, you know, guide liner support system, because once you lose your wire, then, you know, all hell breaks loose. So again, we take for granted how guide sits in, for example, in the femoral approach, but, you know, radio could have many different issues in terms of tortuosity. So getting a good sense of what your guide support is before tackling very difficult lesion is something very important. Take a pause and say, am I going to get good enough support here? And if not, start thinking about using other devices, other supportive systems to help you.
Okay.
Great. Maybe we move on.
Yeah, Michael, please introduce the next speaker.
All right. It's my pleasure to introduce the next speaker, Dr. Ho Lam from Tuen Mun Hospital from Hong Kong again. And he's going to talk on the rare causes of arrest in PCI in the cath lab. Dr. Ho Lam, please.
Thank you, Dr. Lee. Good morning, everyone. It's my great honor to join TCTAP again. I'm Dr. Ho Lam. Today, I'm going to share some rare cause of arrest in PCI for AMI, publication, and CTO. Those are all unexpected excitement, maybe not excitement. So the first case is a contrast-induced cardiac arrest. Everyone has heard about this, but not everyone can see it. I try to share my experience. The patient was a 86 years old lady with multiple medical problems. She was admitted for inferior STEMI with cardiogenic shock. There was inferior STEMI, cardiogenic shock. And this was the angiogram on the left side. You can see multiple vessel disease and with multiple lesion in SHAD and multiple lesion in LAD. So we cannot find the outside, despite we tried many guidings, diagnostic. We even cannot do one angiogram. We don't know the situation, but finally we use a short tube AL. We can find it and we see it. That's a good news. We now know the situation. There's a critical lesion in proximal outside, and there's no fall in the distal outside. But there's bad news also. We inject the contrast. The contrast go to the left and go to the right. And after that, the patient developed PA arrest. You can see then we have to do the CPL. The heart is completely not moving. It's not moving at all. How did I wire the outside in CPL? Actually, the guiding and the outside are in different direction. So in this case, I did not engage the outside. I can't engage. I just shake the wire in a big curve, hit the aortic wall, and then we reverse wire into the outside, and then do the PCI with stenting in the proximal outside lesion. And after that, we successfully rescue the patient. You see the heart is moving again. BP return despite the patient is on inotrope. But we lose the guiding during the intubation, despite we had already put the guide extension to support. And in this part, you see the angiogram is simple, but actually it needs lots of teamwork. My team actually helped me to do all this adrenaline injection, CPL, everything in a very quick way, and also intubation. So after that, so we will do a final angiogram after a successful CPL. So we actually did not do any angiogram. We do it again. There's a good news. You see the whole heart is moving, and we improved the proximal outside lesion, and there's a fold in distal outside. But there's a bad news again. The contrast injection go to the left and go to the right, and the patient develop PA arrest again. So we have to do the reverse wiring in the aorta again. We hit the aortic wall, reverse rewire into the RSA, and then to do the PCI with Lucas again. And finally, we did it, but the patient still have significant ST elevation, strong ST elevation. The heart is not moving very well, so we decide to do the PCI to the mid-AD critical lesion also. And after that, we found the ST elevation resolved. The heart is moving better. This is patient's hand. Actually, patients wake up and then can move her hands. Patient was discharged with smile, say thank you, and survived more than 2 years. So the second case is some rare case, arrest by port in bifurcation. So this is the case. Is it a simple bifurcation? Yes, it's a simple bifurcation. The only drawback is that there's a short distance from left main to this bifurcation. So we do IFS guide, PCI, IFS, and then stand, balloon cross. We put the main branch stand, just at the proximal LAD here. And then the angiogram after that is good. And to save money, we use the balloon to do the port. IFS, so we have to stand from here to left main also. So we just balloon, and then we see that. Do you see anything special? Yeah, here is some haziness, and the patient's BP gradually going down. So I quickly use caudal view to see what happened. You see what happened? Yeah, this is the first image. There's a hematoma at the osteo LAD. The thread was diseased before, but now it looks more severe. And we cannot just open it, open the LAD, because the hematoma may shift and then cause the circumflex. So we have to wire the thread and stand the thread first before we do something on the osteo LAD. It was very difficult to wire. The workhorse cannot go. I have to use filter XTR to wire, and the total time take is 2.5 minutes. But after 2.5 minutes, although it's already very quick, you see, after 2.5 minutes, the LAD had no flow. It's because the blood pressure go down, and then there's a critical obstruction. There's not enough pushing force to push the blood down the LAD, and then the BP further drop, and the further drop in BP and can have no blood supply for the LAD. It's a vicious cycle. So, but anyway, we have to fix it, and we cannot just open the LAD because it will cause the thread. So I plan quickly to put two short stands because it's retroflex thread. I quickly put two stands and then open the thread and then stand the LAD. However, after the first stand, the patient already cannot tolerate and develop VF arrest, and then we have to defibrillate the patient and CPR. It's also my team's great work, and we returned the patient into the sinus reform, and BP was still low on inotrope. But the bad thing is, during the defibrillation CPR, we lose the wire in circumflex. So in this sort of situation, what can you do? I think there's two ways. Either you put the patient on impeller, or another way is to settle it by speed. So I did the fastest left main PCI last year, wire with filter XTR again to the circumflex. It looks easy, but it's not that. This is the most critical part. And use anchor balloon, deliver another stand, and then balloon cross, and put the stand from left main to LAD, and we was by, and the patient was safe. The heart is moving well again. Patient was rescued. The most amazing thing for this case is post PCI-CK was normal, despite all this thing. The case 3 is arrest after small balloon in situ PCI. This is a bit uncommon, but it can happen. This is an old case, 61 years old, he's of gout AF, and patient got non-STEMI, and then we had to do the PCI on AD, and we staged PCI to the RSA CTO 1 year later. So I think you can appreciate from the angiogram. There's a very good retrograde flow. They are excellent cholesterol. You can see from here, the cholesterol from the retrograde is excellent. So can you see anything special in this angiogram? Here, actually, there's a full competition with the antegrade flow. And then that is the outside CTO. You can see that the antegrade flow is very strong. This is a very old outside CTO with multiple cholesterol. You can see that the antegrade flow and the retrograde flow are competing each other. You see the flow competition. So can you appreciate? So, and then probably they are in a very fragile equilibrium with the fold in antegrade and retrograde. So I was successfully, and then we proceed with the PISA. The microcatheter cannot go, so I changed to a small balloon and then open the trap with just a small balloon, Sapphire 10. But the patient developed short after opening with the Sapphire 10 balloon, near arrest, and systolic BP go down to 40 something, with significant ST elevation. Now, I need IV adrenaline. If you can appreciate that it's different from before, the RV movement was reduced. So what is the cause? It's a mystery. Probably there's a change in the equilibrium of the antegrade flow and retrograde flow. The antegrade flow is very strong, and they are in a well balance. Once I open it up, it increased in the retrograde flow, and the retrograde flow is increased, but it's not strong enough to completely take over the retrograde flow. And then they compete each other. Two flow crush together, and then when at the part of their crush is no pressure, equalize the pressure. So the perfusion to the RV was impaired. So the patient are chest pain, and we lose the wire. So how to rewire this dissected I'll say. Now it was closed again. So the retrograde flow take over, and this was after the inotrope everything and stabilize a bit. And then we tried to use workhorse wire the best pace that we can wire. Then probably it's not in a good position, so we then use a crusade, and then use crusade and plus another workhorse wire carefully a few, and make sure that we don't go into the false lumen. Then wire the PDA and stent, and that was the final angiogram. So anyway, it's some very unusual and uncommon case. So this the summary. Today I try to share some uncommon excitement in CALAT. Some contrast-induced cardiac arrest in AMI, pulse-induced arrest in bifurcation, and this is suspected full equilibrium disturbance in CPO after small ballooning. So that's the end of my presentation. Thank you.
Well, thank you, Dr. Lam. 3 excellent cases, very exciting cases. Some of those causes are really sort of rare causes of cardiac arrest. Can I just start by asking you about the first case? So do you think the cause of the cardiac arrest is because contrast flowed down both the left and the right side of the coronary arteries that actually caused the cardiac arrest?
It could be because it happened twice in this case. We inject, and then the patient immediately PA arrest. You can see from the angiogram, the heart completely do not move after one.
Right, because one single injection actually contrast goes down both the left main LED as well as the RCA. So yes. That might be the cause of this sort of contrast-induced cardiac arrest. But yeah, nicely managed. Oh, do you need to put in some sort of supporting device in that particular patient?
It's also a case to illustrate. for this OA lady, we don't have much choice. You can call MO team you refuse. It's not supported by anti-funding for impeller. And IBP is not a choice in those cases. Because you can see that when the patient arrests, you have to do the CPR. IBP need either pressure checker or ECG checker. In those cases, you won't have IBP, you won't have a ECG checker or a pressure checker. If we have more time, maybe in the very first beginning, we put the IBP in this old lady may help, but the patient arrests before we do the angiogram. We just do the angiogram when the patient arrests. So the situation is a bit different. Yeah.
Any other questions? Yes, CK.
Can I ask about the second case? So I wonder how the original left main or distal third looks like. Was there a plan to actually intervene on the left main as well? Or
yes.
This is a plan to just, because it's a very, very short distance between the bifurcation point of the osteo-LAD and the LAD diagonal bifurcation.
Yeah, thank you, CK. Yeah, there's a moderate to severe lesion in the distal left main also. We plan to intervene the left main also. The third ostium was diseased, but it's not that severe. But however, after the POC, the osteo looks much more severe. And the key point is not the disease on the third, is the hematoma formation. And then I cannot do anything. If I do anything, I worry about the shift of the hematoma, the move of the hematoma.
Because I was thinking if the distal left main or the left main bifurcation was actually also involved. So you have only a very short distance to do the pot, which is almost impossible. I mean, you don't have the shortest balloon like 3 mm. So your pot balloon is bound to extend back to the osteo left main. I mean, osteo-LAD.
Thank you. I also learned this case. Whenever I see this situation again, I won't do the pot anymore. I will do the bifurcation and then set the third and then put the stand. That is the wisdom I learned. Thank you. You point out the key point. Thank you very much.
Thank you.
Other questions? All right, if not, maybe we should move on. Thank you again, Dr. Lam. So let's next turn to structural heart intervention. I will have much honor to introduce our good friend, Dr. Alan Young from Stanford University School of Medicine, the USA. And Alan today is going to talk to us on an overview of cardiac arrest during structural heart intervention. Alan, please.
So obviously, cardiac arrest hopefully is not too common in structural heart intervention, but just like the coronary intervention, you have to be prepared. And hopefully I will illustrate a few points with my presentation. This is my disclosure. So I think obviously structural heart interventions have a wide range of physiology. Therefore, to lump them all together is somewhat difficult in this short talk. But I think it's important to point out a few facts is that when you're dealing with stenotic lesions, for example, aortic stenosis, are usually more risky than regurgitant lesions because regurgitant lesions are generally has been occurring for quite a while. So even a little worsening of that regurgitation typically do not lead to cardiac arrest, but they're obviously exception. I think ventricular function we always looked at, but we have to be looking at both the left and the right because a lot of the structural interventions will affect both sides. Therefore, it's important to understand how the left and right are intertwined in a particular physiology situation. I think pulmonary pressures are especially important. So if you can, figure out what the pulmonary pressures are. And also we typically focus on the low end of ventricular function, EF that are low. But at the same time, in structural intervention, when the EF is particularly high, or the other way to look at it is really thickened ventricle, small cavity, there's also could potentially be have error for issues, and therefore the room for error could be sort of small on both ends of the spectrum. I think we don't think about coronary perfusion as much, but as I'll illustrate, the status of coronary perfusion really sometimes dictates the temporal rate of deterioration. So a lot of things that happen in structural intervention could be disastrous, but they usually have a little bit of time. While coronary perfusion, could happen in the next 10, 15, 30 seconds and leads to sort of complete hemodynamic collapse. So you have to be ready to deal with that as well. So I think it's important, as Ajay has talked about, is that cardiac arrest is not suddenly something happens out of the blue. And in structural intervention, also that's the case, meaning there are prodromes of cardiac arrest that you should be looking for. Bradycardia is something is happening in the heart rhythm. So pay attention to what obviously is the baseline. Tachycardia, obviously, whether it's AFib versus VT, is very different, and therefore need to pay attention to that. And also ST changes on the EKG. So just like coronary intervention, that should be paid attention to as well, because where we worked could be very close to the left main or the ostium or right coronary artery. Most of these things you pay attention to, but when blood pressure starts to fall, which is hypotension, then things turn quickly south, and therefore you need to think about what you need to sort of pay attention to. The good news about structural intervention, there's typically there's anesthesiologists present to manage airway, whether you're doing in MAC or doing through general anesthesia. So that piece is actually very helpful, and attention are paid pretty much immediately to the respiratory status. So I think respiratory compromise generally doesn't happen too often, unless obviously we are doing just conscious sedation, which is probably most of the structural heart. We haven't done that yet completely. Mostly still just MAC at best. So in hypotension, I think it is something that quickly you should go through your differentiation or differential diagnosis in your head, whether it's bleeding somewhere, and also could be coronary obstruction that leads to a problem. And tamponade itself, separate from coronary obstruction, could be a cause. And also, you're working on the ventricle, therefore it's LV compromise, or similarly RV compromise is the cause of that hypotension. So therefore, I think quickly when you have a case of hypotension, you have to quickly think through those and eliminate these possibilities very quickly. So let's do a couple cases. This is a case that is a few years ago. Hopefully never have to see it again. 81-year-old with essentially symptomatic AS with dyspnea on exertion and fatigue. Normal PFT is pretty normal, otherwise in kidney function, have a high gradient of 60. EF is a little lower on the normal range of 49%. Has a little bit of LAD disease, but has an FFR in the outside hospital at 0.83. Vascular access is good. So STS was felt to be low risk. And this is actually before the low risk trial has actually completed. So this is before partner 3. So 29 S3 was chosen by my colleague to do this. So this is just, again, something that we prepare for, looking at the area here is 559. The thing that stand out to me when I reviewed this case in retrospect is that how calcified this valve is, how much sort of all 3 leaflet has significant calcification that are thick. That was kind of confirmed on the CT pictures. This is the coronary height, which is on the low side, 8.7 on the left. On the right is also on the low side, which is about 12. So this is something that before the TAVR procedures, you can see the calcium is pretty bulky. So this is the root shot, and you can see it's a pretty good coplanar view, and you can see the leaflets are pretty thickened. So this is the S3, a big valve. So you can see the movement of the calcified nodule. So not too many things can give you hypotension right away and BF and needing CPR. So usually, as we discussed, usually bleeding and things like that takes a bit of time. But if you have no coronary flow, which in this situation, basically, I'm sorry that somehow it's sort of dragging here. I'm not showing that. Okay, better. So you can see that there's no coronary flow in the left main or the right coronary. So that's really a complete occlusion and no flow to coronary. So in those situations, there's not much you can do. If you start thinking about how to, can I rewire the left main? Can I rewire the right coronary? You would I think the patient would not make it. So essentially you have to swap off to something else. It's really support the patient So immediately, and we have access family, so you switch to fem bypass on ECMO, and then you have to basically think about how to get rid of the valves, and obviously sternotomy here, and subsequently a surgical valve. So the patient was extubated and did well, and went home on post-op day 8 with a good ejection fraction. So this is a great save, but again, the sequence is that you don't go and try to figure out what you want to do with the coronaries, is to really support the patient and then remove the problem. So in retrospect, looking at this patient, clearly this sinus of Valsalva is not particularly small. The coronaries are low, and the valve is large. The valve they want to implant 29, and what happened is really clearly missed in the sense that the nodule on the left and right coronary leaflet, the right aortic leaflets are pretty thick, 4 to 5 millimeters thick. And what happened is that if you look at the sinus of Valsalva plus the valve plus the thickness, essentially you have no room left in either one. So that's what happened. So I think it's important to learn in retrospect that this type of scenario, that everything adds up together and you end up in a situation that could be very difficult. So second case is really quick here. 81-year-old, again, mean gradient of 49 for aortic intervention, annular area of 364, 23S3. So you can see quickly here, this is a bicuspid valve, it's type 0. And the valve is relatively on the small side, 364, which is a little unusual for bicuspid. So this is the pre-picture. Now this is, the valve is implanted at nominal volume, and you can see there is some aortic regurgitation. So the operator felt that they should dilate this further. So this is dilated with an additional cc in the catheter, as shown here. So afterwards, maybe the aortic regurgitation a little bit better, but not a whole lot more. But what is, again, unusual is ST7 depression. Why would you have ST7 depression in doing a TAVR procedure? So something is unusual here is that you see some contrast staining here. You can see that there is some sort of compression of the diagonal branch and compression of the OM branch. More pictures. So this patient had a previous angiogram before the TAVR procedure, and the diagonal is a little diseased, but not like that. So the sort of misdiagnosis, if you may, is that something happened to the coronary. Maybe there is embolization. There's something went down the diagonal. But I think what is sort of missed is that why is that contrast hanging out in near the left main? So this was sort of relooked 4 hours later because of persistent chest pain and ST changes. The patient was stable hemodynamically, but continued to have ST changes. And when they went back in and take a look, you can clearly see that the annular rupture. Now you can clearly see hematoma getting around the left main, under the left main, and extend into the diagonal and likely a bit of the OM branch as well. So again, this is an annular rupture due to a bicuspid valve with relatively calcification. Probably what happened is that the valve is actually a little oversized, and the extra dilatation causes the rupture. So just keep looking at the coronaries, but that's not the issue. So obviously at this point, there's not a whole lot of choice but to sort of try to fix the pseudoaneurysm that's been created along the left coronary cusp with a narrowed neck, only about 2 millimeters. But you can see that's why you don't see it in the beginning. And therefore, as time goes on, there's hematoma forms and take off the left main. And therefore, this eventually, actually during operation, it was a small to moderate pericardial fusion at that time. So this has actually occurred over approximately 4 hours. So a contained rupture doesn't necessarily give you the typical pericardial fusion tamponade situation. So you'll be very vigilant about looking at trying to understand what is happening. And I think a structural intervention, that's really something that sometimes could be pretty occult, especially nowadays. We don't do TE anymore, and we just do a quick bedside or transthoracic to look for pericardial fusion, also aortic regurgitation. So this patient did well. Now, this is almost 2 years ago, so it has done well for over 2 years. Final case is a quick one. This is, again, a woman on steroids for connective tissue disease, have a bicuspid type 0. So this is a regular case again, pre-dilatation because of the type 0 bicuspid valve. And then a valve was implanted. And immediately there is known to have a pericardial fusion. So this one is actually caused by the LV laceration by the wire. You may say, well, the wire doesn't look too bad, but this is unfortunately a small ventricle with a small cavity, and the LV laceration in a patient on steroids is not uncommon. So therefore, extremely careful about maintaining the wire position in performing TAVR procedure. Unfortunately, this patient had many complications as besides just the tamponade, have other issues, and eventually led to multi-organ failure and passed in 2 months in the hospital. So finally, just to sort of touch on other interventions, I didn't have time to really go through a mitral clip, left atrial appendage closure, ASD closure, so forth. Again, in those situations, hypotension usually is bleeding somewhere, and tamponade is obviously relatively easy to detect because all these procedures have typically imaging associated with it, so you can detect those early. Obviously, LV compromise, if you have caused more regurgitation, for example, with using mitral clip and so forth. So the conclusion here is cardiac arrest is uncommon in structural interventions, but you have to be aware each step of the way what are the possible complications and what are likely at that time. So prodromes are common and need immediate attention. So do not ignore the little bit of hypotension, do not ignore the bradycardia, and you need to diagnose and treat. I use this word for, a lot of times nowadays we talk about primordial prevention, meaning that you really need to know the patient's clinical details, imaging details, and case-specific potential risks very thoroughly before you go to do the case. Especially nowadays, we do so many TAVRs in a day. Sometimes all TAVRs case patients look alike and very easy to forget what are the details. So important to really sort of look at each case before the procedure and understand what are the risks in that particular patient. Thank you so much.
Well, thank you, Alan. That's an excellent overview of the structural heart interventions and in particular the TAVR procedure. I would like to see if there are any questions from the panelists. Alan, can I start by asking you about the second case? I think it's sort of unpredicted, concealed sinus perforation, sinus rupture. But if you are going to redo the case, would you use a smaller valve, or you rather not to post-dilate with 1 more cc contrast?
Right, so I think it was a 360, something like that, and therefore using that valve size is probably about 20% oversized. So I think it was oversized already. And unfortunately, the perivalvular leak is probably due to the annulus, dimension. It's more oval than just pure post-dilatation. I don't know for sure whether the post-dilatation did anything because there's no before and after to compare. So sometimes the question is, in these little higher risk cases, should we do it under TEE so we can see things a little bit better? And because we have no way to tell, right? Because when we're doing it, hemodynamic's okay. But the clue in that one is that something happened to the coronary. So why would something happen to the coronary? So you should stop and not just say, well, some embolus, something like that. It's like, maybe we should actually have this patient sedate the person further, or general anesthesia, go ahead and intubate and evaluate the valve with the TE on the table. You would have picked up that hematoma. But anything outside from transthoracic, you can pick it up. So when you have a puzzle, like why is the coronary looking like that? This has to be something, right? So in multiple areas, not just one area. So it has to be something occurring around the left main and so forth. So, and also that staining that you cannot just say, well, there's a leaflet there, sometimes it was staining, but that doesn't happen like that either. So clues were there, but it was kind of missed and sort of dismissed because we always want to finish the case and say, well, it's okay, blood pressure is okay, heart rate is okay, let's just move on to the next one. But I think that you have to step back and there's an issue here. Why are things like that? If you don't solve that, but we all have that sort of, trying to rush off and trying to finish the case. And
yes, that's a great case. Thank you.
Alain, I have a short question, and your third case is we also rarely experience the LV laceration case, even though we used Sapari small copper wire, and that can happen. Is there any risk factor? Is that we are same cases, small LV, some fragile patient, we experience LV laceration, and on the basis of your large experience, is there any confidence risk factor for LV laceration?
Yeah. When I have a patient who's a female patient, elderly, on steroids, I get nervous no matter what we do, because sometimes just the wire itself, and therefore it's extremely important not to put pressure on the wire, right? Because sometimes you extra advance and pushing through and the person holding the wire in the back is maybe not experienced. It really that wire has to be staying put completely. If it's a little short, it's actually okay, rather than further in, especially see that wire bends up a bit, then it acts like a little bit of a cheese cutter of that wire to just cut through every beat of that ventricle. So we still use the extra stiff implants, but I think a Safari small is fine, and it may be important to place it using a pigtail, because we also should just use an AL1 and place the wire. But as you know, it can sometimes come out funny. In a small ventricle, you may have not a whole lot of choice. So to be sort of safe, probably exchange out to a soft, long wire, put a pigtail in, put whatever wire in there to make sure it's perfectly, round pigtail, right? So the ventricle will actually compress on it a bit. So a lot of things, but still, these steroid patients could lacerate anytime. So that's the part that is kind of scary. When it's done, you have to wait a little bit longer and making sure you check the pericardial fusion for a little bit of time, because sometimes it's delayed a bit. So you don't want to rush out of the lab and say everything's okay.
Great. Well, time is running short. Alan, last question for your first case. So if you have predicted sort of high risk of coronary obstruction, would you protect the both coronaries or do a basilica before the procedure if you are going to do the case again?
Yeah, if I do the case again, I think those valves are hard, right? Because they're very thickened. It's like you cannot, yes. You have to use a chainsaw to do that basilica, because it is so thick. I would have probably, if this is a not operation patient, let's say they are higher risk and not low risk, that you would protect a new chimney stents into both the left and the right. So you have to have 3 places to access this. But obviously he's low risk, so therefore a question is whether he should have surgery to start with, because those 3 leaflets of calcification looks really ugly. And low coronaries at the same time.
Yes. All right, maybe we have to move on.
Okay, so I'm gonna introduce the last speaker, and the Dr. Carl Long Chief, Prince of Wales Hospital, Hong Kong, and he will be talking about the hemodynamic crash during PCI and TAVI in low EF patient. Okay, Dr. Long.
Thank you for inviting me to share with you a case of hemodynamic crash during PCI and TAVI in a low EF patient. So my patient is a 70-year-old chronic smoker, history of hyperlipidemia, AF, CV in 2018, small bowel angiodysplasia, history of multiple PCI with PCI to CERT in 1996, LAD in 1999, and RCA in 2001. And he was admitted for acute coronary syndrome in 2020. And he also has a bicuspid aortic valve with moderate AS, and at that time the EF is 45. So he undergo a coronary angiogram which show triple vessel disease. The LAD is calcified tortuous with 70% stenosis in proximal mid to distal LAD diffuse 50%, calcified circumflex 18% stenosis, calcified RCA with mid RCA 70% followed by 80% stenosis. So he underwent a stage PCI with rotor shock to RCA and 4 overlapping DES, and subsequent stage PCI to a left system with rotor and 1 DES to circumflex and OM. And wiring of LAD was difficult due to a tortuosity and calcification, and patient cannot tolerate the procedures and hence decided for re-angiogram and PCI later. However, he was readmitted again for heart failure this time, and the ejection fraction dropped to 27, and the mean AV gradient is 33. And we angiogram show similar LAD disease, stent in circumflex and RCA was patent. And he actually developed cardiogenic shock shortly and required an urgent BAV, and condition was stabilized afterwards. And then we proceeded to do the pre-TAVI CT, and we showed that the aortic valve is heavily calcified and indicating severe AS, and the STS score is 11% for mortality. And this is the echo. You can see the aortic valve is heavily calcified. The ejection fraction is 20%. And the LA and LRA is dilated, and there's a mild mitral regurgitation. So this is the corneal angiogram. The circumflex stent was patent. And you can appreciate in this LAO cranial view, the LAD is severe disease in the proximal, diffuse disease distal, and very calcified, and there is a severe angulated proximal to mid LAD. And there's difficulty in wiring to the LAD, so probably because of the heavy calcified and angulation. So the right coronary stent is patent. There's mid, I would say 50% stenosis, but most likely non-obstructive. So this is the CT. You can see this is a type 0 bicuspid aortic valve, and you can see heavy calcification in one of the raphe. And you can see the annular, the sinus is big, but the STJ is very small. And you can see many calcification protruding in the STJ, and the mean average diameter is only 20. So the annular diameter is 581, so corresponding to the use of 29 cc Sapien 3 valve. And the aorta is very calcified. And mind you, this is very challenging anatomy because this is a bicuspid aortic valve. The annular sizing is 29, very narrow STJ with protruding calcification. So this is what we recommended for sizing, because in bicuspid aortic valve, sometimes the ceiling is supraannular and at the valve level. So what we now do is recommended to use a circle method to size, to have an approximate idea the sizing of the aortic valve. So this is an imaginary circle of 26 millimeters diameters, corresponding to the use of 26 millimeter Sapien valve. This is an imaginary circle, 29 millimeters diameters, corresponding to the use of a 29 Sapien 3 valve. So on the left side is 26, on the right side is 29 millimeter circle, and at different level is areal full tract annulus at 3 mm above, 6 mm above the annulus, and also 9 and 12 mm above the annulus. So you can see on the left-hand side, the circle actually touch both the annulus. And while for, if you use a 29 Sapien valve, actually is the circle exceed beyond the level of the intercommissural distance. So we now recommend to use this method to have an idea of about the sizing of the valve in the bicuspid disease. So if the circle is too big, and beyond the commissure, there is a risk of rupturing. So if the circle is just enough to touch the commissure, so we expect sealing will be there. So if the circle is undersized and does not touch the commissure, there is a risk of PVL or even valve embolization. So I will refer you to see this consensus document. This is a very good article published in Cardio Therapeutic 2021. So my PACES is this kind of anatomy. The annulus is big, but the actually the sealing point is very small. So the access is generally okay for a Sapien 3 valve. So in this case, because of the sealing is most likely at the aortic valve, we chose actually a 26 millimeter valve, nominal fill. And if we use the annular sizing, we would choose the 29 valve, which may risk of rupturing at the commissure of the aortic valve. So this patient is actually having very bad heart failure. His cardio heart association class 4 is unable to line fat with borderline blood pressure and also tachycardia. So because of the LAD, we still need to fix it. So we have some discussion before should we do the PCI first and then stage do the TAVI in the same section? Should we do it like a stage procedures? So we do the TAVI first and then stage PCI to LAD at the same time or bring the patient back. And concerning about the support, I think this patient would need certain degree of support. And we could also do it by impeller. We can do the impeller support PCI first, and then remove the impeller and then TAVI the same section. Or we could do the TAVI first, and then maybe stage procedures, insert the impeller, and then do the impeller supported PCI, but probably not at the same section because we don't want to cross the aortic valve with the impeller, with the valve just implanted. Or we do it using the ECMO support. So because of the funding issue and also because VA ECMO actually provide a complete cardiopulmonary support to both the PCI and TAVI procedures, we chose to insert the VA ECMO upfront in this patient. So we do it in the usual way. We use the right radial for the Sentinel cerebral protection device. We do the pacing via the screw-in leaks. Sometimes we used to pace by the LV wire, but in SAPIEN, loss of capture may result in valve emboli. The other thing is sometimes if we use the LV wire, we have to push very hard, and there's a minimal chance of perforating if we push too hard during the procedures. So this is the angiogram through the guiding. So you can see actually LAD disease actually progressed somewhat and the severe angulation and calcification. So there's some difficulty in wiring because of the heavy calcification. We managed to wire with the microcatheter support, and we attempt to pass the IFUS catheter down, but IFUS cannot go beyond the proximal LAD. So with the ECMO support, we decided to proceed for rotobation. So we did the rotobation. So we can see actually there's some difficulty. When we push harder, the rotor jumped forward and did not come back. So the guiding started to suck in. And during the rotobation, actually the blood pressure dropped. And the ECMO has to be dialed up by the intensive care unit physician. And also the anesthetist at the head, at the up head position actually has to give some of the inotrope support, and the blood pressure actually dropped down to 40, 50 during the procedures. So I actually stopped the birth, tried, but luckily I can get it back. So actually I read the article from a Japanese colleague about the halfway rotor. So instead of doing the conventionally, we do the rotobation for the whole length of the disease. But if there's a severe tortuosity and calcification during the vessel course, sometimes the risk of rotor is high, and then we may opt for halfway rotobation. So not the whole length of the calcification need rotobation. So if the risk is too high, then halfway rotobation and it can be considered. So it actually avoids burn entrapment and vessel perforation. So this is retrospective studies, 300 patients, and halfway rotor was successful in 90% of case, and unsuccessful case requires switching back to conventional rotobation, and no burn entrapment and perforation in halfway rotor. And while in conventional group, there is a 5.5% of rotobation. So this is you can see that halfway rotobation, no perforation, and in conventional rotor group there is some perforation, although that doesn't reach the statistical significance. So I do the IFUS. This is the IFUS. You can see there's some old stand heavy calcification distally, and you will see that there is a protruding calcium nodule proximally. Probably this is the cause of difficulty in passing the IFUS down the LAD. So rotor did some modification in the proximal LAD and as well as the mid LAD. So we do the balloon post-dilatation using the NC balloon, but you can see the proximally the NC balloon did not open well. So we use a 2.5 shockwave and a 3.0 shockwave more proximally. And then put a long DES to the proximal to mid LAD. We left the distal disease for medical therapy, and an additional short DES 3.5 18 to the from osteo to proximal LAD, and post-dilate with a 3.0 NC distally and 3.5 NC proximally. This is the angiographic result. So this is the IVUS. Actually, the stent opened quite well, and some eccentricity because of the calcified plaque, because of the protruding calcium and the perfect osteo landing here. So the rest of the procedures is quite straightforward, crossed with a standard AL catheter is a strict wire. And because BAV has been done already, and we just go for implantation of the valve. This is a 26 millimeter Sapien 3 nominal fill. And I did this procedures under TE guidance because this patient is basically in active heart failure and unable to tolerate procedure without general anesthesia. So this is the positioning of the valve. This is the deployment. So you can see very nice deployment. So this is the final result. And we also re-angio because there's some worry about the RCA status because of the relatively low coronary height on the RCA. We just do a selective angiogram to make sure nothing is happening. So this is the TE, basically good valve position and trivial paravalvular leak. Ejection fraction improved to about 30. Mild mitral regurgitation. So ECMO actually provide full cardiopulmonary support during the PCI and TAVI procedures, but it increased the afterload of the heart, and therefore we need to titrate the flow to minimally required to support the patient during the procedures. So in case of this, we actually run the ECMO at very low flow, 1 to 1.5 liter. And then if the patient got like hypotension, bradycardia, and instead of like giving an inotropes, we're fearing what to do, we just dial up the MO flow. We have an ICU colleague to take care of the MO. We have the anesthetist to take care of the hemodynamic so that we can focus on the procedures. Also, in case of severe calcified and angulated segment, half-wave rotablator may be considered to avoid serious complications. So thank you very much for your kind attention.
Okay, thank you. Thank you. So, and this case is very excellent and very complicated, very nice case. And any question or comment from the panel? So I have one the question to you, and this patient is bicuspid valve, also very severe calcified region. LAD is very important vessel, also porcine aorta. How about the concomitant bypass surgery plus surgical AVR? Did you consider for surgical procedure for this patient, or initially intended to the PCI and the TAVR procedure?
Oh yeah, thank you for your question. So this case alternatively can consider CBG and also AVR, but as the patient is in a very bad shape, class 4 heart failure, ejection fraction 20, STS score 11. So surgeon actually turned down my patient, so I have to proceed to this high risk cases.
Okay.
Would you consider using a self-expanding valve for this one?
Yeah, excellent questions. Yeah, we did actually consider the use of self-expanding valve, which is probably less. A bit more better conformed in the elliptical valve. But because of the very narrow STJ, it's only 20, we are worried about the pop up or even pop down, because usually after the release of the valve will find a comfortable position for itself. And we actually measure the balloon actually doesn't hit the STJ, actually all within the sinuses. Even if we normally place not to intend putting more further down into the LV. So we decide actually Sapien is probably safer. And also given the STJ protruding calcium, sometimes the valve may actually catch the calcium, causing emboli and stroke.
Great. Well, Galong, can I ask, you actually have anticipated a complex PCI procedure for this patient. Would you consider actually staging both procedures in a separate session with impeller support for the PCI and then come back for the TAVR procedure, or the other way around? instead of doing two procedures in the same session?
Actually, this patient is critically ill, and we have the end mode inserted. We want to do everything in one setting instead of bringing the patient back for twice. But I agree with that. We may do a TAVI first, and EF may improve, and then do a PCI without support. The other way around, we may do a PCI first with the impeller, and then bring the patient back for TAVI. But probably if there's funding issues for the impeller, and if we chose to use the ECMO, probably we do everything. And also LV, I mean, the LED is also important for the EF. So we hopefully do everything and let the patient have the best chance to recover.
How much contrast did you use? I'm just worried about the contrast issue.
Yes. We do this using the IFAS. Maybe
Okay.
I forgot, maybe 110, I think.
All right. Very good.
How did the patient do in terms of any recovery of LV function?
Yes. I haven't mentioned that actually the 1 month echo showed the ejection fraction improved from 27 to 36, and
Great.
patient was able to go home, probably doing well.
Wonderful. So I think it's time over, and I really appreciate all panel to contribute to Hkstent and TCTAP session. And this session absolutely wonderful. This is a part deal with the first of a lot of complication in cath-lab with regard to PCI and the structural heart intervention. Especially, I think this session would be helpful for the beginner and the early career interventional cardiologists. And thank you everyone and to contribute this session. And I hope always be safe in COVID-19 situation. And looking forward to see you next year TCTAP in-person meeting. Thank you for joining.
Hopefully.
Thank you.
Thank you.